Okay, thank you. I think so far 16 participants has joined. I think we can start our today's seminar. My name is Dr. Henok. As a background, I'm an anesthesiologist, and now I'm currently attending my fellowship program at St. Paul's Millennium Medical College for critical care medicine. And today's seminar will be given by Dr. Finot Debebe, and it will be on subarachnoid hemorrhage management and also diagnosis in the ICU. Dr. Finot is a passionate associate professor for the emergency and critical care medicine at Addis Ababa University. She holds her master's in health science education and also subspecialty training in at St. Michael's Hospital, University of Toronto, Canada. She's currently working at Addis Ababa University, actively involved in clinical, academic, and also research activities. Without further ado, I'll give the floor for Dr. Franz.
Thank you so much, Dr. Henok, for the kind introduction. I will be talking about subarachnoid hemorrhage. Let me start sharing my screen. I think you can start from, right?
Yes, you can start.
Okay. So I'll be talking about subarachnoid hemorrhage, one of the most important neurovascular emergencies worldwide. We'll be talking about mostly focusing on the diagnosis and management. I have nothing to disclose. I have nothing to declare. I was able to work in a neurocritical care, and then I've seen how patients are managed. Otherwise, there's nothing that I would declare. Regarding today's session, we will try to see why subarachnoid hemorrhage is important, try to describe the clinical manifestations of subarachnoid hemorrhage as much as possible, in the diagnosis and imaging modalities, early treatment, and also some expected complications in their management. Please feel free to stop me anytime if you have any questions. It's just I'll be going through the general highlights of the definition, the diagnosis, management, and monitoring. So subarachnoid hemorrhage is very important because it's a neurovascular emergency, and it's associated with the higher mortality, and also like the complications are very severe, and it varies across the world. The highest incidence has been reported in Japan, but in other parts of the world as well, it has been associated with it has been reported to be lower. It's leading to the subarachnoid hemorrhage. So as much the subarachnoid space. So as much as possible, I may be asking questions. It would be great if you guys can participate in the chat box so that we can see. So why do you think we should care about subarachnoid hemorrhage? It's just, why do you think we should care? Why should we care? It would be great if you can type the answers in the why you think it's important in the chat box, please. Okay. Yes, mortality rate is very high. Excellent. Yes. Most of the patients, even some of the patients, around 12% of the patients with subarachnoid hemorrhage, they don't even arrive to the hospital when they die. So it's associated with a higher mortality. So that's one of the reasons that we should be caring about subarachnoid hemorrhage. Any other thing that? Yes, it's potentially treatable, especially if it's early detected. Yes, that's also very important because early detection, early monitoring, and early management are associated with a better outcome. So it's very important that we detect it as early as possible, and then we can have a good outcome subsequently. Yes, and also subarachnoid hemorrhage is significantly associated with complications. Complications may be related to neurological complications, or also like other system complications are also very common. So as a result, for the complications, we need to know the possible complications, and we need to manage them accordingly as well. That's excellent. Any other? If there's any other? Yeah. Yes, like you have already mentioned, the higher mortality, and also not only that, it affects mostly younger age. Like most of the patients are around 50 years old. The majority are between 50 to 55. So relatively for these patients are relatively younger, and also because it affects a younger age, especially in those with risk factors. So we care significantly about subarachnoid hemorrhage. In the complications you have already mentioned, and the cost of care is also significantly high, because the management, the diagnosis, and the monitoring is significantly high. So we care about subarachnoid hemorrhage. And furthermore, it needs a specialized care. Specialized care in the neuro-intensive care is also very important because mortality is also mortality is significantly associated with mortality is also significantly reduced with caring for subarachnoid patients in a multidisciplinary way, and also in specialized units where patients are admitting at least more than 35 patients in an ICU. So in those type of ICUs, they have a better recovery and a better outcome. So it needs multidisciplinary care. It needs intensive monitoring. So it needs and it's also very costly. It is associated with high mortality, higher complications, and affects the young most of the time, and also like females are highly affected as well. So considering everything, we need to make sure that we know about subarachnoid hemorrhage. So what are the risk factors? What do you think are the risk factors? Before we go to the etiology, what do you think are the risk factors for developing subarachnoid hemorrhage? Okay. What do you think are the risk factors? Sorry, I'm sorry. I'm having some difficulty, technical issues. Mm.
Hypertension could be one of the risk factors.
Can you say that again, please? Yes.
Hypertension.
Hypertension, yeah. Okay. What else?
Other vascular malformations.
All right.
Unsecured aneurysms.
Okay. Previously unsecured aneurysm can be a risk factor. Yes, excellent. Yes. Yes. So like you guys have already mentioned, most of the time, like the risk factors associated with subarachnoid hemorrhage include like hypertension. Most of the patients most of the patients with subarachnoid hemorrhage have history of hypertension. And not only that, tobacco use is mostly associated with is also considered as a risk factor. That's why maybe the incidence in Japan is relatively higher than the other setups. That's one of the things that have been mentioned. And also alcohol and also tobacco use. Alcohol use has also been associated with the subarachnoid hemorrhage. And furthermore, like familial risk factors, those families with the history of subarachnoid hemorrhage have relatively higher risk of developing another subarachnoid hemorrhage. So these are the major risk factors that have been associated. In some some disorders like Ehlers-Danlos and other disorders may be associated with subarachnoid hemorrhage. In you mentioned previously as well, if there was a previous history of if there is a previous history of aneurysm, then it may be a risk factor for developing another aneurysmal subarachnoid hemorrhage, because these patients can have rebleeding and can have subsequent complications once they have been diagnosed with a subarachnoid hemorrhage. So considering the etiology, most of the time we have we can classify them as spontaneous and also non-spontaneous, and there is also a traumatic type of subarachnoid hemorrhage. But the major classification that we have is based on whether it's aneurysmal or non-aneurysmal. Aneurysmal subarachnoid hemorrhage may be there, and then non-aneurysmal also may be there. So the most common one is aneurysmal subarachnoid hemorrhage, and it accounts for around 85% of the spontaneous subarachnoid hemorrhage that we have. And then there are different arteries can be involved, like the anterior cerebral artery, middle cerebral artery, the PCA, posterior communicating artery, anterior communicating artery, basilar artery can also be involved. From the non-aneurysmal types, the mesencephalic is the one that's mentioned, and also arterial dissections following neck trauma, carotid artery dissection or vertebral artery dissection, and other types of arterial dissections may be involved. And then AV malformation may also be a risk factor. Patients with underlying disorders like polycystic kidney disease and others may be at risk of such type of bleedings. And furthermore, if you see the prognosis of all this, the one that's associated with a better prognosis is the perimesencephalic one. The others, the aneurysmal subarachnoid hemorrhage is relatively associated with relatively bad outcomes because of the extent of the bleeding and also the development of complications. While in the perimesencephalic one, most of the time you won't find any type of aneurysm, and they usually have the best or the better prognosis compared with the other ones. So this is just a picture of the circle of Beals. As you can see the different parts of the arteries, the ICA, the middle cerebral artery, the posterior cerebral artery, the anterior cerebral artery, and their branch, and also the basilar artery, which is not really very common, but it can happen actually aneurysmal bleeding, but compared with the others, relatively less common one. Regarding if you see the pathophysiology of subarachnoid hemorrhage, most of the patients can have this aneurysm, and then aneurysm would rupture. It can rupture anytime, and when it ruptures, it will result in different pathophysiologic. It will activate different pathophysiologic mechanisms, and those pathophysiologic mechanisms will lead to the complications. So mostly these patients, they will have disruption of the blood-brain barrier, and they will have problems with autoregulation. There will be there may be significant inflammation because of the hemoglobin release. There may be significant inflammation that can potentially affect the patient's outcome, and necrosis and apoptosis will be there, and then there may be different cytotoxic and also vasogenic edema can also develop. All these things would result in early brain injury or early brain edema, and that's significantly associated with a bad outcome. So honestly, it's very difficult to understand all the pathophysiologic mechanisms that are occurring in for subarachnoid hemorrhage, but there have been studies, and there are ongoing studies, and for possible even novel therapies, there have been ongoing studies. And then subsequently, patients would have delayed cerebral ischemia, which usually occurs later, which we'll discuss later on. But the pathophysiologic mechanisms have been studied, and it's multifactorial, and different things are happening at the same time, and that will lead to vasospasm, that will lead to capillary thrombosis, and that will lead to complications that would arise when you treat patients with subarachnoid hemorrhage. So the signs and the symptoms, can you just do you mind dropping them in the chat box, please? Thank you. What do you think are the signs and the symptoms? So yes, severe sudden headache. Yes. How is it usually explained? How is it usually stated? How do patients usually describe it, like specifically?
The worst headache.
The worst headache of their life, Adel? Yes. Yes, the worst headache of their life, yeah. And then other potential symptoms that can be there. Yes, thunderclap headache, which is yes, excellent, yes. It's called, yeah. Additionally, they can have associated neck pain because they are bleeding into the subarachnoid space and also the meninges as well. So there may be like a significant neck pain maybe there, and meningeal signs can also be positive. Excellent, yes. Anything else that you want to add? Yes, vomiting can also be there. Definitely, they may complain of vomiting and nausea. So most of the patients will have like early headache, which is usually mild, and then subsequently they will have the severe type of headache. That's called the worst, like you have already mentioned, the worst headache of their lives, or thunderclap headache. That's severe headache, and that may be associated with neck pain, that may be associated with vomiting, that may be associated with altered mental status, and they may even have like seizures as well. Those things can be present during their presentation. So if anyone comes with a risk factor, those with the hypertension or the risk factors that we have mentioned, like tobacco use, alcohol use, or family history or previous one, then you have to consider that. Yes, patient can also have photophobia as well. And then they can have the vomiting and like and also like the headache, and also the nausea, and the other clinical manifestations that we have mentioned. And furthermore, they can also have these neurological deficits. They can have like localized neurological deficits. They can present with hemiparesis, quadriparesis. They can have like only cranial nerve abnormalities, and also they can even become others. So the range of clinical manifestations can vary significantly based on the severity of the illnesses that they have. And then how do we diagnose them? What are the diagnostic modalities that we can use? Like how should we diagnose them? So CT of the brain, yes. What type of CT of the brain? Like, should we use a contrast, non-contrast, or what type of yes, excellent. So we should have an non-contrast CT of the brain. That's usually diagnostic immediately, especially in the first 6 hours. If you can do the non-contrast CT of the brain, then you can diagnose up to 100% of the patients with subarachnoid hemorrhage. That's excellent. And how else? What else can we do for these patients? ALP, yes. Yes, ALP and also CSF analysis should be done. So previously we used to do ALP later on, but the current recommendations are saying that we can do the ALP within after 6 hours of the clinical presentation. If we do ALP, then it may be helpful in diagnosis. It is helpful in diagnosing subarachnoid hemorrhage. So you would see your CSF xanthochromia after 6 hours of the presentation, if you do the ALP, that will be helpful. Not only that, the ALP can also be, the lumbar puncture can also be therapeutic, and it can help with the ICP as well. So it has so many other good reasons. There are so many good reasons for us to do the lumbar puncture. Yes, and excellent. CT angiography. CT angiography is also very important. CT angiography is important because we want to know where the aneurysm is, especially like we have discussed, like the aneurysmal subarachnoid hemorrhage. It's very good to know which artery is significant, which artery is involved in the size of the artery, and also like subsequently, because early management should also be started as early as possible so that the patients can have like a better outcome. Yes, MRA and DSA are very important. Yes, the MRA is also very important, and also the most important one, like especially the most specific one is the DSA. If you can do DSA, especially for those patients where the CT angiography is not very clear or is not very specific, or you couldn't find the affected vessel, then it will be important to do the DSA. That's using a fluoroscopic method, and you'll have the multiple images, and you'll try to get, it will show you the affected blood vessel, so that your team, the neurosurgeons and also the neuroradiologists can like subsequently plan the management of the patients. MRA is also important, but the thing is maybe like it may take a while, and then to do the MRA may not be readily available in most of the setups. So MRA is important, but the most specific one and the most diagnostic one would be the DSA, and the first one to do would be the CT angiography, so that you know the culprit vessel, and once you know the culprit vessel, it will be easier to plan your management and subsequently help the patients have a better prognosis. So there have been different grading systems for the prognosis. If you know some of them, the first one is the so there are clinical grading, and also there's also radiologic grading. Before that, I want to show you an image. So what do you think is this one? What do you think is this one? What is this drawing? It's as well.
This is DC.
Yes, this is the DC. So as you can see on the image, you can see that there is an aneurysm here. This is just following the blood vessel, and this is just an aneurysm there. And this is very important just for planning the management and the patient subsequently. So clinical grading systems, is there any clinical grading system that you can think of for like prognosticating these patients and also planning their management? Yes, the Hunt and Hayes, right? This the Hunt and Hayes classification system is very important because it's a clinical classification system, and it will help you just to see. It will help you with the clinical, like with the planning management and also assessing the severity of the subarachnoid hemorrhage. Any other one that you know? Yes, there is, yes, the WFNS, right? The World Federation of Neurosurgeons scale. That's also one of the other clinical scale. Most of the time, the WFNS is usually used. The handheld health is also has been, yes. And then considering radiological manifestations, based on you can see, you can assess the severity of the subarachnoid hemorrhage using the Fisher grading system, the modified Fisher. You can use the modified Fisher, and then you can also classify assess the degree of the severity of your illness. So, like this is the WFMS. It uses the Glasgow Coma scale for grading, and those patients with the WFMS of 4 or 5 are usually thought to have a bad prognosis, and they have a lower GCS, especially those less than 12, GCS less than 12, and also lower than that. And this is the modified the modified. So if you see the first one, you see that there is a subarachnoid hemorrhage, and then that subarachnoid hemorrhage is not that big. It's like the thickness is very small, and there is no intraventricular extension. While in the modified Miller Fisher 2, you see that there is some intraventricular extension. There is bleeding into the ventricles, and then that on MF3, you'll see that there is significant thick bleeding, but there is no extension to the ventricles, and like if there's extension to the MMF4 is associated with a very bad prognosis, and there is significant thick bleeding, and that's also extending to the ventricles. So if you have a MMF4 and WFN is 5, it means that the mortality is very high. So you have to be expecting, you have to be anticipating like not a good outcome, and maybe you have to counsel the patient, the family, accordingly. Now that you have seen that, you have graded them, how do you like to monitor them? Like once they are admitted to the intensive care unit, how should we be monitoring them, and how should we be managing them? Yes, the class and scale is also there. Yes. Yes, yes. There are different types of grading systems, and that's for assessing the severity of the subarachnoid hemorrhage. Yes, but the most widely known are the most widely used are the WFS and the Miller, the modified Miller. So regarding monitoring of these patients. Yes, the most important is the hemodynamic monitoring. Actually, the management starts in the pre-hospital system as much as possible, because we have to be able to, it's good if we can detect it as early as possible so that we can prevent the complications and also intervene as early as possible. So like the hemodynamic monitoring is very important. The vital signs, especially the blood pressure, is very important. Yes. Yes, and also serial neurologic examinations, because that will detect the early complications as much as possible. So that's why it's recommended to admit these patients in specialized neurointensive care units so that we can have trained nurses and also trained physicians that can help with the monitoring and early detection of like the early detection of complications. And furthermore, there are things that you can do, like a continuous EEG monitoring, which is very important in such patients, because they are at risk of developing seizures. So these patients can have seizures, and you can detect this as early on, and then you can stop, or you can at least you can treat the seizures if needed. But most of the time, whether it's beneficial or not, it's maybe controversial, but continuous EEG is one of the recommended ways to monitor this patient, especially those who are comatose, because you don't know what's going on in the brain, and you don't know whether there is a seizure is going on. If there are overt seizures, then maybe you may need to start treatment. Furthermore, TCD is very important in this type of patients, because with your transcranial Doppler, you can detect vasospasm early on, and then this maybe transcranial Doppler is excellent. It may be there may be some issues with the specificity, especially because it's operator dependent. Otherwise, it's an non-invasive tool, and then it can help you with detecting complications as early as possible. You can see even the size of the ventricles using your transcranial Doppler, and there are people trained on this. And then if we do ultrasound as well, it will be easier for us. So TCD is one of the most important things. Yes, you have to monitor electrolytes, because one of like the most common, one of the things that's associated with the subarachnoid hemorrhage is a hypometry, and it may be associated with the bad outcomes as well. And there are issues related to magnesium as well. So like we want to make sure that these patients do not have at least hypomagnesemia, and make sure that you treat magnesium as well. Other the basal angio is very important, especially we'll be discussing on like delayed cerebral ischemia, but like there are specific periods that are that you think these patients may be at risk. So you may need to consider like repeating the CT angiography, and also MRA may be done. And yes, the ICP monitoring is also very important, because these patients, especially one of the complications that you'd expect is increased ICP. So in this type of patients, you may need to insert your EVD and or like or other types of like ICP monitors, and then make sure that you are monitoring the patient's condition. So already have mentioned most of the things. The CTP, how is it helpful? Can you comment? How is the CTP helpful? Can the CTP be helpful? Why do we use the CTP, CT perfusion? So the CT angiography will help you in detecting the abnormalities that are associated with the one, so that you know the culprit artery. About the CT perfusion, how is it helpful? So we usually use the CT perfusion. Just we're good if yes, yes, excellent.
Maybe in detecting early ischemia or diffuse vasospasms.
Excellent. So we usually do the CT perfusion so that we detect the vasospasm as early as possible. If there is any sign of like especially if there is any significant deterioration, clinical deterioration, and if you suspect any vasospasm, then you can order your CTP, and then see if there is a true vasospasm, and then subsequently plan your management as well. The CTP would be helpful in that aspect. Otherwise, I think the continuous EEG and also the invasive monitoring. Can you think of like any other invasive monitorings that can be done? This also mostly checked in patients with like a traumatic brain injury, but it can also be used in patients with subarachnoid hemorrhage. It's proposed, but the evidence may not be there. Can you think of the things that can be like that we can consider like invasive monitorings, or like how?
EVD is one of the good.
Say it again, please. The EVD, yeah?
EVD monitor.
I'm sorry, I couldn't hear. I'm sorry. Wait, chat box. Can you write it in the chat box, please? The ABD, yes, the ABD, yes, and some advanced like brain monitoring mechanisms, like can you think of other things other than that? So in the base setup, they also do like the brain oxygen, the VO2, like the brain oxygen content monitoring. The brain oxygenation is also monitored. And furthermore, sometimes they do like dialysis, cerebral dialysis, microdialysis may be done. And there are also like invasive monitorings for the seizures, for seizure as well. So all these things can be considered in those in available setups, but the evidence for patients CCP, can you describe it further? CCP, like you mean the cerebral perfusion, CPP or CCP? Yeah, the CPP, yes. So cerebral perfusion pressures, yes, definitely, because it's early on, like the most one of the things that we will manage is the blood pressure. And with your blood pressure, if you have an EVD or like intraparenchymal like monitors just to monitor the for an increased ICP. If you have some intracranial monitoring, then you can get your CPP, and your CPP will tell you whether you want to make sure that the CPP is at least in the normal range. And then subsequently, you try to prevent complications, and you may need to adjust even your cerebral perfusion pressure so that you meet uh, that like when, especially when they develop complications like vasospasm, you may need to increase your CPP to make sure that the areas that are like getting some or are getting enough blood flow. So CPP is very important. Yes. Okay, but those the advanced ones like the brain oxygenation and also micro dialysis, they also measure lactate and other things as well. So all these things can be done, but the evidence for those things are not significant. So considering the treatment, most important thing is patient stabilization, because these patients can have a range of symptoms. They can present with like mild, like just headache and with a Glasgow Coma scale of 50, or they can come with like complications, aspirations. They mean you need to protect the airway, so the ABC of life is always important, and then making sure that they're not having like pain, or they're not having like high blood sugars, and they're not anemic, and they are like not hemodynamically unstable, or like if there's any, you want to make sure that you are attaining your like euvolemia as much as possible, and then early treatment of blood pressure, and also you have to assess them for possible surgical intervention or like radiographic like a neuro yes, radiological intervention with the neuro radiologist as well. So all these things should be done, and then that should be planned as early as possible. So regarding the blood pressure, what do you think should be our target? If you can comment on that, it will be great. What's our target? How should we go with the blood pressure? Should we allow high blood pressure? How high should we leave the blood pressure? Should we allow like a low blood pressure? What are the possible risks? And then especially before, like immediately once they have been treated in the pre-hospital system, and then they came to the emergency and they have arrived to our ICUs. And then once before like securing the aneurysm, what's our target? We have to actively treat higher blood pressure, yes, but like when would we treat it? With what number? Starting from what number should we be treating? If you have any, because like these patients with higher blood pressure, they are at risk of developing like rebleeding. We know that patients with subarachnoid hemorrhage, they have high sympathetic outflow. They can have higher sympathetic outflow, and that may be associated with the higher blood pressure. But in the meantime, you want to make sure that they are not bleeding significantly as well, especially those with an unsecured aneurysm. Yes, a systolic blood pressure of less than 160 is usually recommended. There is no strong evidence, but still, at least targeting blood pressure less than 160 will be safe. Usually between, it might be acceptable to, yes, it might be acceptable to leave the blood pressure between 140 to 160 prior to the like securing the aneurysm. Even up to 120 may be okay, but you have to make sure that you have to look at the patient's clinical condition, because you don't want to create also like a cerebral hypoperfusion and complications that can arise. So as much as possible, you want to keep the blood pressure on the safe range. You want to avoid hypotension, and you don't want them to have higher blood pressure more than 160 as well. So a safer range between 140 to 160 may be there, but the evidence, there is no clear evidence on that. So, but make sure that they're not really hypertensive, and that you have stabilized them, and they're not having any pain, in all the ICU cares that you provide for all the patients, including like the supportive care, the nutrition, and everything would be very important. And then subsequently, you have to, yes. And the other most important thing is variation should be avoided as much as possible rather than the number, the specific number. The most important thing is the variation as much as possible. We have to make sure that the blood pressure is not varying like significantly. If that does, then it's associated with the worst outcome. So as much as possible, we have to make sure that the blood pressure is not varying, and also like we have a fair blood pressure control. So regarding early brain edema, I think we have seen the previous slide, with the pathophysiology. So these patients have a higher risk of developing brain edema in the first 72 hours, and because of the inflammation, because of the chemical changes that are happening in the brain, because of the disruption of the brain barrier, because of the release of inflammatory cytokines, because of so many things, micro, the thrombosis that happen, the platelet dysfunction, and everything can have a significant impact on and that may lead to cerebral edema. And cerebral, this early brain injury or early brain edema, maybe it's associated with worst outcome. They will have higher mortality and higher risk of complication, and usually occurs within the first 3 days. So we have to try to make sure that these patients do not only have primary, also we have to try to prevent secondary brain injuries as much as possible. That's why they should be admitted in a monitored setting, and make sure that these patients are getting the proper monitoring and also the proper early treatment, so that they don't develop complications. There are also different scoring systems, but mostly this is for a radiologic scoring system to detect early brain edema, so that you can manage them as early as possible and then try to prevent the complications that can arise subsequently. So what other complications do we anticipate with the subarachnoid hemorrhage? Yes. 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 So yeah, we are worried about rebleeding because we are worried about rebleeding. We are worried about hydrocephalus. We are worried about ischemia, and we're worried about volume contraction. Yes, we want to avoid it as much as possible. Yes, and also SIH is also possible. Yes, definitely. Most of the patients have associated sodium abnormalities that we have to give due attention for. So rebleeding, most of the time, these patients, when does rebleeding occur? When does it occur usually? Yeah, the most important is the vasospasm. Excellent. Yes, the rebleeding is mostly we're worried about rebleeding the first 24 hours, and majority of the rebleeding occurs within 6 hours. And even though it's not occurring in all the individuals, or the incidence of rebleeding is 3 to 6% in the first 24 hours, but still it's associated with a bad outcome, especially in the first 6 to 12 hours, but mostly in the first 6 hours. So we have to make sure that these patients, if they have been taking any drugs, the previous drugs or any anticoagulants, in addition to all the stabilization, all the neurologic assessments, and all the neurologic monitoring and the supportive care that we are providing, we have to make sure that we reverse this anticoagulation as well as early as possible. We have to administer fresh frozen plasma or PCC, or depending on what the patient has been taking. If we are in a setup where the PCC is available, then you have been using your PCC, or also the others fresh frozen plasma, or your vitamin K, or your anticoagulant reversals would have a good role in such type of patients, because this is also associated with a bad outcome. And also not only that, but patients can also develop DCI, or delayed cerebral ischemia. This is very important for patients with subarachnoid hemorrhage. Usually the delayed cerebral ischemia occurs within like usually after the surgery. It can I'm sorry. Yes. Oh yes. So your delayed cerebral ischemia is one of the most important complications that today I anticipate in patients with subarachnoid hemorrhage. So this patient, they will develop vasospasm, and that vasospasm usually occurs between the 3rd and the 14th day, but it may even occur even up to 21 days after subarachnoid hemorrhage. So that's why, especially those with the higher grades of subarachnoid hemorrhage, it will be very important to admit them to the neuro ICU, and then you may need to monitor them for days because this complication can occur with like up to 21 days. In these patients, they may have focal neurologic. They may present with focal neurological deficits, or like hemiparasis, or like other neurological deficits may be there. Change in mental status may be there. It's just from the inflammatory reactions, what's going on in the brain that's associated with delayed cerebral ischemia. And then your imaging modalities, like I've already mentioned, we can do the CTP, CTA. You can also use the RTCD to diagnose to see what's going on in the brain, so that we can treat them accordingly. And what is the drug that's associated with the prevention of this delayed cerebral ischemia? That we should be using, and if there are any other drugs that you know that can be used for like this preventing the delayed cerebral ischemia as well. If you can yes, nimodipine, right? Yeah. Nimodipine is very important. That's the most important drug that we should be administering for all patients with subarachnoid hemorrhage as much as possible. That's the most proven to be associated with like a reduction in delayed cerebral ischemia, because one of the most important complications following subarachnoid hemorrhage is delayed cerebral ischemia, and that's associated with bad outcome. And then you can prevent it with using like nimodipine. What form of nimodipine should we be giving, IV or PO? Well, what do you think? What do you guys think? Should we be giving IV or PO nimodipine for these patients? Yes, PO, because the IV one is associated with a reduction in the blood pressure, and that reduction in the blood pressure, you don't want to have a significant drop in the blood pressure. Usually, the nimodipine, we can give it we give 60 milligram, and usually we give it for 21 days. And the other one is there have been drugs, different drugs, including magnesium and also statins that have been tried in such patients, but the evidence is not significant for such type of patients. And also like IV nicardipine has also been tried, but the calcium channel blockers, you can still consider them, but like the other drugs like magnesium, and also because people are trying to induce hypermagnesemia, and there was no good evidence. So unless you have contraindications or like something like that, otherwise there is no indication for such drugs. And also the statins have also been tried, but there is no significant benefit. So the only one proven to have a good outcome, and also in prevention of delayed cerebral ischemia, is the nimodipine. Once they develop this delayed cerebral ischemia, how would you manage them? Is there anything that you can do for them? just to make sure, let's say that you have a patient admitted with subarachnoid hemorrhage and has like it has been the third or the fourth or the fifth day, and then the patient has suddenly developed a new onset of left-sided like arm weakness, and you have done your your CTP, and it's showing vasospasm. So how should we go about that? How should we be managing such type of patients? What do you do for them? Because we know that like there is, if you're suspecting vaso, yes. Okay, verapamil. No, any other thing that you can do other than that? Mhm. So yeah. So in this type of patients, even though this is not significant, we can try doing like blood pressure augmentation. So with your blood pressure augmentation, what you're trying to do is you are trying to increase your mean arterial pressure, and then subsequently with your mean arterial pressure, you want to make sure that there is good blood flow to the areas to the areas of the brain that's affected by the vasospasm. So you may try a blood pressure augmentation by subsequently increasing the blood pressure and seeing the patient's response. So the evidence is not that big, but we can see that there there will be like in some patients, in most of the patients that I've seen, and also like even in the literatures, there will be clinical improvement, but the long-term outcome is not like it may not be significantly different. So that's why the evidence is not as big. But the thing that you can do is at least you can try to increase their mean arterial pressure, and then subsequently monitor them every hour, like depending on your intensive care unit and on the standards that you use. You monitor them and then see if there is any clinical improvement. And with that, you maintain the blood pressure on that area, and then try to see if that neurological recovery is like is there for a long time. In the meantime, you want to treat like treatable causes. You want, because patients with subarachnoid hemorrhage, they can have fever, so you have to make sure that you have addressed that. You want to make sure that they are EU volemic. You don't want to have hypervolemia. You don't want to have hypovolemia as well. But you have to make sure that they're not significantly dehydrated, or they don't have any pain, or like all the treatable causes should be treated. But if it's truly like a delayed cerebral ischemia, and if you're thinking about vasospasm, you can try blood pressure augmentation. For blood pressure augmentation, you can use your vasopressors. Most of the time, what's recommended is either to use norepinephrine or phenylephrine just to increase the blood pressure and see the patient's condition. Especially for those with a secured aneurysm, the blood pressure, you can increase the blood pressure higher. Like you can target for a very higher maps, and then follow the patient's condition and then see if that's reversible, because clinically you will see the change in their neurological status once you have increased their blood pressure. So like we don't specifically have have a map cut off, but like you can increase your map with like 10 to 20, and then see the patient's clinical condition. Otherwise, it depends on the area of aneurysm and also the extent of the bleeding that they have. It usually plan this with your neurosurgeons and interventional radiologists that you have, if there are any interventional radiologists. Otherwise, you want to make sure that you see the blood pressure. I have seen systolic blood pressure up to like 200. We have been increasing the blood pressure up to even 440. Systolic blood pressure have been even to a higher level, but you don't have to do this. They just you target your map, and then progressively evaluate the patient, and then see if like the neurologic changes there or is maintained. And then sometimes like you may use drugs like Mindreno. They are as you know, Mindreno is a phosphodiesterase inhibitor, and it's associated with vasodilation. This may not be significant, but you can use it. In such type of patients. Okay. And I think we're running out of time, right? And the other complication that you'd expect is what's this on the CT scan? It's hydrocephalus, right? So this is hydrocephalus, like you may need to have your EVDs inserted as early as possible. It will help you with the ICP management, with the ICP monitoring, and also like with the management of ICP until your culprit vessel is secured. So it's very important in these patients. Usually it can be done even at the bedside, just inserting the EVD and monitoring the output of your EVD and monitoring the patient is also very important. And your patients are at high risk of developing seizure as well. So there is no direct indication for like anti-seizure medications. What we know is phenytoin should be avoided in these patients as much as possible because it's associated with a higher mortality. Like the newer drugs like levetiracetam are recommended for such type of patients and are associated with good outcomes. So if you have like a seizure or if you like with your EEG monitoring and also like if you have any seizure activity, then this drugs should be started. But for the rest of the patients who don't have seizure, there is no strong evidence. For high risk patients, you may consider it, but like the evidence is not significant. So treating seizure is important, and just to make sure that the patients are will not have subsequent bad outcomes unless you may consider it in severe in patients with like bad WFNs or the MF and the Miller-Fisher grading. Like if you have like a bad score, then you may consider this anti-seizure medications, but the evidence is only for those with a seizure. And the ICP is also one of the most important complications that you anticipate. So like with your like you may use drugs like a hypertonic saline or mannitol, depending on the patient's condition. Otherwise, the managements that you use for ICP also work here, like your sedation, making sure that they're comfortable, and then like and also like making sure that you have managed all the potential like precipitants, and then your EVD would be very important. So maybe like if there's significant hydrocephalus, you may need to drain some CSF and try to decrease your ICP. So all these things can be done for such type of patients, and your hypertonic saline is also very important. And also if you or mannitol would be very, very important in managing this. You have to be cautious with the hyperventilation because of its risk for like cerebral vasoconstriction and also possible ischemia. So you have to be cautious on that. Otherwise, the rest of the management similar to the other patients is also very important in patients with subarachnoid hemorrhage. So this is just a slide summarizing on the possible complications that you'd expect: the rebleeding, the hydrocephalus, CSF drainage, and also like the intracranial hypertension, the ICP, monitoring the ICP and also managing it accordingly, because higher ICPs are associated with bad outcomes. You want to make sure that at least your ICP is in an acceptable range between 20 to 22 maximum. Even lower is recommended sometimes, so you have to individualize it to the patient. You have to make sure that you have prevented as much as possible. Try to monitor for delayed cerebral ischemia, and then like if there's any DCI as well, you have to manage it. Other than the drugs, maybe you may need to do like balloon angioplasty and other advanced procedures with your in collaboration with neuroradiologists if they are available, with neurointerventional radiologists if available. That's something to consider. And then consider continuous EEG monitoring is also important in those type of patients. So definitive treatment, this is usually done in consultation with your neurosurgeon. So you may need to do coiling the aneurysm so that it doesn't, so that there won't be any blood accumulating in the aneurysm, and also there won't be complications. Or you may do clipping. So the most preferred one is usually the coiling is relatively preferred, but in some patients you may need to You may need to do clipping as well, surgical clipping. It's usually done for, especially for those younger than 40 years old, you may need to consider that. So they may even do like flow diversion in other like intervention may be planned, but the most common ones are either coiling the aneurysm or like clipping, and this should be done within the first 24 hours as much as possible, and that's associated with good outcome. But like even in the developed setup, even in most setups, they cannot do this within 24 hours due to logistic issues. So you may extend it to at least in the first 72 hours to make sure that these patients are the blood pressure is controlled and clinically stable, and they have been diagnosed, and they can go for such type of procedures. So furthermore, like similar to the other patients, all the complications with your deep vein thrombosis, like other like nutritional problems and other things are also common in this type of patients. So you have to make sure that you treat them thoroughly and monitor them thoroughly. And they can have respiratory complications that are at risk of aspiration. They can have like they can develop pulmonary edemas, so and also at high risk of complications like pneumonia as well. So we have to monitor these patients, and also they can have cardiovascular complications. They can have arrhythmias. They can have cardiomyopathies. ECG genes are usually common in this type of patients, and also like hypokinesis. Maybe their troponin may be raised and may be associated with a bad outcome. So you have to monitor for all those things as well. And also electrolyte abnormalities, especially the hyponatremia, is very important. So hyponatremia may be related to your like SIADH, or it may be related to like your cerebral salt wasting syndrome, both of which are very, very common in such type of patients. And you don't want to have hyponatremia in these patients because it may be associated with like a development of cerebral. You want to make sure that there is no like with, as you know, sodium is osmotically active, and if they don't have enough, if the sodium is lower, then the risk of like fluid shift from the extravascular space to the intracellular space will be high, and they can have cerebral edema. So as much as possible, we want to prevent it. You can give hypertonic saline. You can give like stable salts, or like pure dietary supplementation is important. And if you're in a setup where there is access for like drugs like hydrocortisone should be considered in such type of patients. It's helpful once you have it's helpful in such type of patients, similar to corticoid. So it's helpful in such type of patients so that you will have like good sodium. So electrolyte monitoring is very important. Making sure that their magnesium is at least in the normal range is also very important. But hyponatremia is very critical, and it should be monitored, and you have to make sure that they don't develop complications from the severe hyponatremia that they can have. Furthermore, they can have like long-term problems, cognitive impairments may be there, may not be functional, physical disabilities, emotional challenge, emotional disability, like depression, anxiety, and other things are very common. So you have to make sure that their recovery is also should be considered. So subarachnoid hemorrhage is like it's a neurovascular emergency. We have to try to diagnose it as early as possible and manage as early as possible. Like the neurointensive monitoring is very important. Early if possible, like if there's any intervention that can be done in the setup, in your setup, especially if there's any coiling or clipping or any other intervention that can be done for this patient should be done as early as possible. Intensive monitoring, especially we need to have like nurses and also clinicians trained in providing such a care so that they can detect early complications, including the rebleeding, including the delayed cerebral ischemia, in any type of vasospasm should be detected. And then rehabilitation is also very important in such patients. So yeah, so this is just a slide summarizing the early brain injury that occurs within the first 24 hours, then the delayed brain injury between 3 to 14, but it's also possible. It can stay even up to 21 days, and then the recovery is also very important. And making sure that they're not anemic as much as possible. There are evidences showing that higher hemoglobin may be beneficial, but they're not strong. There are ongoing studies going on whether we need to target higher hemoglobin so that we improve the oxygen delivery to the brain is also very important. But and also long-term outcomes are also important in such patients. So I just run through it so that because we have run out of time. There are questions here, so if you can answer it, it would be great. Which of the medications associated with the increased mortality? Yes. Phenytoin is associated with the bad mortality. It's yes. So as much as possible, make sure that you don't give your patients like phenytoin. Then your drugs like levetiracetam are very important, and they are helpful and they are associated with good outcome. And which one has a best prognosis from the ones listed here? So we have classified them as aneurysmal and non-aneurysmal, and like usually the aneurysmal ones are associated with the unfavorable, like relatively worse outcomes when compared with the non-aneurysmal one. So this would be the answer would be the perimesencephalic one because it's associated with a bad outcome. Well, the best prognosis is associated with the perimesencephalic. They usually have, they usually respond and they will not see any abnormal blood vessel on the CT angiogram or on your DSC, and then they will have like, they usually do good compared with the others. And less sensitive to detect DCI. Okay, so like, we have not discussed this in detail, but like transcranial Doppler is very sensitive most of the time, but it may be operator dependent. So you may have some challenge using it. Otherwise, the CT angiography is excellent in detecting. MRI is also okay. CT perfusion is also great. The DSA is the gold standard. So all these things can be helpful depending on the setup and depending on the operator. The TCD sometimes may not be reliable. Otherwise, all the others are associated with the good detection rates. So, considering the effective treatments for preventing and managing ICP, there are new recent studies saying that we can use a lumbar brain. EVD is also important, hypertonic saline is also important. So the answer would be like targeting map with a greater than of 90. Compared, it's important as well. We have to make sure that your CPP is in the range as much as possible. So preferably between at least like 65 CPP more than 65 to 70. And if you think that they're having ischemia, you may even go higher than that. So that's also important. So if you have any questions or comments, now the floor is open. Thank you.